Okay, good morning, all, and
Good morning.
welcome to the fourth day of the class. Um, and I'm confident things are going well within your groups, um, as I can see the feedback coming in. So please keep it up, and we see how far we go through till tomorrow when we make the presentations. Okay, as we do, we'll have to make a recap of what we went through yesterday, and then we'll see if there are questions that you have. Okay, yesterday we continued with the aspects of meta-analysis, but focusing on how to evaluate further our results to indicate or find signals we can explore more to see how they may be influencing our findings and our results. So we looked at the issue of heterogeneity, um, and I mentioned there are two aspects of this. So the studies that have been included in our systematic review may differ from the clinical perspective as well as the methodological perspective. From the clinical perspective, I mentioned this can reflect in things like the patient composition within the studies, the measurement and definition of the intervention or exposures in the studies and the outcomes. And methodological heterogeneity may reflect in the aspect of the processes of the studies. So these two together lead to what we call the statistical heterogeneity. And this statistical heterogeneity is what we actually deal with when we do the meta-analysis as a result of clinical and methodological heterogeneity. And I mentioned that the statistical heterogeneity is evaluated in the meta-analysis through what we call the I-square statistics, which is reported in percentages. So if you get a percentage of the I-square, it indicates the amount of differences that exist in the between the studies that is not due to chance alone. So, and I presented some thresholds that people use to evaluate the importance of the heterogeneity that may be there. So once you think that the I-square is high, and this I-square usually is accompanied by the p-value, reflect whether the differences in the studies are statistically significant or not. I mentioned that this test requires many studies to get a clue of what is happening, and it has been recommended that from 10 studies, then it becomes clearer. Of course, you can do it with any number of studies, but you need to be aware that that if you find no statistical significance, it's just that you do not have enough power to detect it and may not be as a result of no differences between the studies. So you bear that in mind. So once you have decided that the I-square is um, big enough, in addition to your expert knowledge of that topic, you can decide to go into other aspects to evaluate what could be explaining this or causing these differences between the studies. And so we can go into things like doing subgroup analysis, doing sensitivity analysis to make this evaluation. One point I mentioned as a follow-up to our discussion 2 days ago on the two approaches to doing the meta-analysis, fixed effects and random effects, is that the test of heterogeneity reflected in the I-square is not a basis to decide whether to use fixed effects or random effects meta-analysis. This is common in the literature. People use it, but it is wrong to do it that way. And I encourage you to avoid doing that. Once you attend this course, avoid doing that because it is wrong. There are many things that are done out there in fanciful ways. People are confident to report it with very good smiles, but not knowing that they are doing the wrong thing. So in going forward, when you do your own study and you do a meta-analysis, don't decide on using fixed effects or random effects based on the I-square value. Using fixed effects or random effects is on the basis of the assumption you make. And hopefully I've convinced you enough that use random effects. You are safe, and if for any reason there are no actual differences between the studies, you will still get fixed effect estimate. Okay, we went into publication bias. We discussed the problems that are there, the reality we face in science, that for some reasons, many of them are obvious. Many studies that are done are not published. And so when we search the literature, we will usually fail to get all the studies that exist. And because of this, the studies that are collected and included in the meta-analysis do not provide a full representation of all the studies that have been done on that topic. And so taking a few of these studies and analyzing them and presenting the result will bias the topic because there are studies that are missing. And so this is a reality. This may be, for instance, that big studies are more likely to be published than small studies. Studies with interesting results are more likely to be published than studies with results that are not so interesting. Studies that agree with the convention we know are more likely to be published than studies that go against the convention that is there. And so for these reasons, some of these studies get missing. And it may also be in the aspect of language. English studies are more likely to be published in international journals than studies written in other languages. So these factors come into play. And what do we do? The first thing is that we should ensure that we have a comprehensive search of the literature, search databases, the formal ones, search the informal ones, search the gray literature, contact experts in the field, search reference list of the studies you include, and so on and so forth, so that you ensure that you have included comprehensively studies that are there. And then within the meta-analysis, we can also, to a great extent, evaluate possibility that we have publication bias. I presented the issue of the funnel plot and some tests that can be done to give an indication. These approaches do not take the place of comprehensive search, do the comprehensive search. And these approaches have their limitation because they are based on probability estimating what may be there. And there is a room of inaccuracy to an extent. So we talked so much about subgroup analysis, how this can be done, and this can be motivated based on the heterogeneity you observe, or this can be motivated on the question you are addressing, thinking that there are subgroups in the population that may be of interest with regards to the topic. So you can do subgroup analysis, but also emphasizing yesterday that you need to state the subgroup analysis beforehand, and this needs to be included in the protocol you have developed. Don't do a post hoc decision on this, put it beforehand. So when you do your meta-analysis, you can evaluate this within subgroups. And meta-regression, we mentioned that this is an extension of the subgroup analysis in which different factors you have considered that may be playing a role in your study or trying to cause the heterogeneity, you will be able to collect them and include them in the analysis and adjust for several factors at the same time. Unfortunately, RevMan does not have the capability to do that. Sensitivity analysis, we also mentioned to be evaluating our assumption, trying to see if there are things you can think of that may explain the results. For instance, if you have low quality studies and high quality studies, and you have done your meta-analysis, including all of them, you may think of, well, if I remove the low quality studies, do I have the same estimate or different estimate as at when both low and high quality studies were analyzed together? So we discuss issues of reporting and publishing and updating systematic reviews, and I hope these were clear. And we had the hands-on meta-analysis practice using RevMan, which many of you expressed that it was looking interesting. Of course, when I teach this course and when we get to the meta-analysis, you can see everybody is excited to play with this. But of course, yesterday, several of you had challenges following up. We have the videos. I hope you have received them, and so you can go back and try to practice this yourself. And I mentioned there are several videos online you can look at to improve your skills in doing this. But you can see that this is workable using RevMan, and there are other programs you can use, Stata, SAS, comprehensive meta-analysis. So in a nutshell, this was what we went through yesterday. I hope that they were clear enough for you. But if not, and if you have any question now, please, the room is open. Any question?
Please, I have a question, but it's not related to the risk recap.
Yeah,
Please.
Go ahead.
Okay. Please, it's with regards to the quality assessment, the EPHPP quality assessment tool. It used to be biased against cross-sectional studies. And at the end of the day, there are a lot of questions that you can't confidently check for cross-sectional studies. And maybe at the end, you may end up indicating that the study is low or moderate with respect to quality. wouldn't that be downplaying the actual quality, or wouldn't that be reducing the value of the actual quality of the paper based on the EPHPP quality assessment tool?
So you said it used to be a bias, or I couldn't understand the first part of your question.
The questions do not favor cross-sectional studies.
Okay, yeah. Your question is quite relevant. This Josephine, eh?
Yes.
Okay. Yeah. So what happens is that I mentioned, please. Okay, the mics are. What happens is that I mentioned that each of those tools used to appraise the quality of the studies has a limitation on its own. Each of them has a limitation. Okay, yeah, Prof. Atluma is saying here that the recordings are in the Telegram platform. So if you have not downloaded, please go and get it to your system. Thank you. Okay, so each of them has a limitation to what they can do. There are rooms for improvement. I've used them and I know there are rooms for improvement, but this is what you can do and this is what we have usually done. Many of these tools may not be developed by core epidemiologists who know what you need to appraise across the study designs. So if I go to EPHPP tool, I take it and I want to use it. What I will do is I can add questions that will help me to appraise that study. So if, for instance, you discover that for cross-sectional studies, the questions they have asked are inadequate to provide appropriate quality assessment of cross-sectional studies, then the aspects you think are missing, you can include questions on those aspects. And we say we adapted those tools, adapted in the sense that we included some questions we believe were important but were missing in the tool. And so what happens is that at the end, you can actually include your updated or adapted tool as an appendix or supplementary file in your paper so that reviewers can see what you have done. So when you do this, you are able then to evaluate those aspects that may have been missing from the original tool. Does that answer your question?
Yes, please, it does. And then I have another question. I don't know whether we are yet to do it. Maybe, but I'm asking because we did not cover it yesterday. What if the same cross-sectional studies, which do not have like exposure and exposure like the way we did it yesterday, how will you be able to analyze it using the RevMan? Because it's, you are having the just one category of people at one point in time, and you are it's not like in two groups comparison and control, and you are comparing them like how the RevMan was yesterday. So how will you go about it?
Yeah, the thing is that if you look at cohort studies and cross-sectional studies are quite similar. The only difference between them is that cohort studies involve follow-up, you follow people. But in terms of other aspects, in terms of how the exposure exposure group is defined, is more or less the same, and that also goes for case control studies. So in cohort studies and cross-sectional studies, you will usually have the exposed group and non-exposed group. And it's inherent there. You just have to find it out. But as I mentioned, when you deal with observational studies, you will be interested in getting the estimates that have been adjusted in those studies. And that means that in most cases, you will not have the numbers. And even if the numbers are presented, let's say they present numbers for exposed group, unexposed group, event in exposed group, event in unexposed group. You will not be so much interested in that because they are not adjusted, and you know that observational studies are likely to be biased, confounded, and different things play in there. So you are looking for the adjusted estimate, and that you focus on getting the odds ratio, risk ratio, or whatever estimate they have calculated but adjusted. So what I showed yesterday was to present the numbers so that in case, for instance, you're dealing with something like a randomized control trial, so you have the intervention group, the event in intervention group, the control group, the event in a control group. So in the randomized control trials, you know that these issues of confounding are not problem there. So you can just take those numbers and analyze. But when you come to observational studies, then you need to get the adjusted estimates. And so the odds ratios, when you get the odds ratios and the confidence interval, you can then calculate the log odds ratio and then the standard error for that. But in essence, what I'm saying is that if you have the cross-sectional studies, it's the same way as you do the cohort studies that you do them.
All right, thank you very much.
Okay, any other question? Please ask if you have. This is your time. And by the way, today will be the last day of the teaching. Of course, you're free to ask on it tomorrow, because tomorrow is the D-Day when we will see the fancy and the encouraging work you have done. So please, if you have questions, feel free to ask so that we can address them. Okay, it seems there is no question. What we will do now is that we can take a short break. We'll come back at 9:30 my time, so you have our 7 minutes break. And once you are back, I will send you to your rooms where you go to deal with this issue. Of this paper. We have covered a lot this week, and now I can see you're already an expert in the area. And as you go home, a journal sends you a paper, a systematic review paper with meta-analysis, and ask you to review. And that is what we want to do today, to use the knowledge we have gained to critique published papers. And these published papers I've selected. So, yeah, we have covered everything. They are all green now. As you can see, there are some issues we'll discuss later on. But we'll go for the break and we'll return, and then I'll push you to your room. Okay, see you.
Okay. Dr. Bright.
Yes, please.
I wanted to clarify something. We're supposed to do the in-class activity 4.
Yeah.
Yeah, but the 2 classical papers, I couldn't find them. The Green, Hodge, and the Morand.
You didn't find them. They should be. Yeah. I mean, you don't really need to read them, of course, because
okay.
What they have presented is what we have gone through this week.
Okay.
Yeah.
All right.
So please don't log out, because I need to assign you to your rooms now. Don't log out. Yeah.
All right.
Who else was trying to ask? Okay. See you in a few time.
star 1 to copy this call tune at 26 pesos for 60 days and subscribe at 65 pesos for 30 days.
Please, can you mute your mic? This is being recorded, please. Okay, welcome back. This is what we want to do now in class activity 4, and each group has its own paper to read. So we're going to critique it. So you can have this in mind as you go to discuss in your group. I will give you up to 10 o'clock my time, so you have sufficient time to really critique these papers. Read and critique it. Check out for what was done well, what was not done well, what was unclear, what can be improved, and as a reviewer, what will you look at for in these papers, and you can recommend rejection or major revision or minor revision. So have this in mind as you go. We have gone through a number of things this week, and which will be your guide in assessing these papers. if papers that cover all this really is a sign of a good job. But if things are missing, then signs of poor job. So you should look out for those things we have covered in going through this activity. Okay, I will send you to your breakout rooms now. Is there any question with regards to this so that we can?
Mine is a question, just a follow-up. Yesterday we looked at in-class activity 4. I don't remember whether
yesterday was 3.
No, 3. Sorry. Okay, because there was a paper we looked at, which was yesterday's. You said we shared the same paper with group 5.
Group 5, yeah.
So I wanted to be sure it's not the same paper. But thank you.
No, it's updated there. So you should have a class activity 4 paper in your folder.
Okay. Thank you.
Okay.
Yeah, and Dr. Bright, you said we have 1 hour?
No, you have half an hour. So you just have 27 minutes now to discuss.
27 minutes. Okay,
yeah, and come back to the room.
Okay, thank you.
Yes, who is just joining? Who is joining now? Hello. Who is joining now? Akin, you are in group 5, eh?
Yes, I am.
Okay.
Thank you.
I see a name here, Lily. Lily, which group are you? Hello?
Leander here, I'm in group 1, but I've not received notification.
No, I sent you that already, Leander.
I have not received it.
Can you go out of the Zoom and come in again? Akin, you're back.
My network is very terrible.
Okay, so I send you back again. Rich, what group are you? Rich?
Okay. That's basically what I'm saying. That's what I said.
Augustus, you.
Okay, welcome back. Welcome back.
Thank you.
I hope you had sufficient time to look at these issues. So what we do, we start with group one. I just have some tips here based on what we have covered. You can highlight, but the first thing is that when you start, whoever is presenting for each group, tell us what the question. You can tell us first the title of the paper, the journal it was published, the question they have addressed, and then what is the conclusion of their research. Then you can go through this aspect. These are based on what we have gone through this week. Okay, group one. Who is going for group one?
Leander.
Okay, group one, we looked at the title of the paper is the title of the paper, Maternal Mass Index and Risk of Fetal Death, Stillbirth, and Infant Deaths. And the question was to review systematic review and meta-analysis
Please go on. Your time is going.
Systematic review and meta-analysis of cohort studies of maternal BMI and risk of fetal deaths, stillbirths, and infant deaths. I want to get both.
For each group, you have 5 minutes to make your presentation. Maximum.
Okay. Now, the conclusions of the study is that minimal increases in maternal BMI was associated with increased risk of fetal deaths, stillbirths, neonatal deaths, prenatal, and infant deaths. That was the conclusion. Now, we couldn't find any protocol that they used. They didn't indicate in the study the use of a protocol, and they didn't indicate whether the protocol was registered and published. Yeah, the search, we saw that they used only PubMed and Embase, the Embase database, which we think is narrow, and they should have searched more databases. The period, even though the period of search was relatively long, 1966 and 1947 respectively for the two databases to 2014 is wide enough that as far as the number of databases searched is concerned, we said is small, only 2. They could have done more. And they used only one reviewer to do the data extraction, which we thought they should have used maybe at least 2 reviewers to do the data search. That one they could have bought more papers. The quality appraisal, I think they used the fixed random model, which is good enough.
They used
the fixed random. Yeah, they use the fixed random model.
fixed effects.
Fixed effects. No, sorry. No, they use the random effects model. I think
random effects.
They use a random effects model, but they also use a fixed effects model to look at studies that had, you know, that were separated by race parity or diabetes status, and the risk which has differences in these two. They use a fixed effect model to pool the effects of these things before including them into the study. They generally use a random effect model. So the data analysis, I think, was right, and they quantified the heterogeneity of the studies. They presented them here. I think the heterogeneity was not, we didn't have a lot of, it was small. They are presented in the paper here, was done.
Okay, your time is up, group one. A few things you have noted. I think you can also on your own read the paper again to see the issues, but you have noted a few things. One is that the database search was not comprehensive enough, searching databases, and you didn't see any indication of whether they contacted experts in the field or searched the grey literature. And then you mentioned that they use both fixed and random effect, and what would have happened there is that they use the I-square to make a decision in that paper.
Yes.
So some of this you have to take note, and you said they use one person as well to do the data extraction, which is of course that is not what it should be, and that is what we're discouraging in this. So which journal was your study published?
It was published in the
JAMA.
JAMA, yeah. So
JAMA.com.
You know that JAMA is ranking around the first 5 journals in medicine. So you can see that some of these things can still go through in some of these top journals, even when they have been inappropriate or inadequately undertaken. Okay, let's go to group 2.
The title of our study is Association of Corticosteroid Treatment with Outcomes in Adult Patients with Sepsis. It is both a systematic review and a meta-analysis published in JAMA International Medicine. The objective of the study is to conduct a systematic review and meta-analysis of the efficacy and safety of corticosteroids in patients with sepsis. And for the things that we thought they did well, they used 3 databases: Medline, Embase, and Cochrane Central Register of Control Trial. Even though the database is just 3, the fact that 37 of the studies used in the review were all randomized control trials. So we think incorporating Cochrane Central Register of Control Trial is appropriate, and we would give them fairly good, even if it's just 3 databases. Secondly, the meta-analysis model was the random effects model. They also reported risk ratio mean difference at 95% confidence interval. And they used 2 independent reviewers, which we of course think is appropriate, and which we of course think they use the right meta-analysis model. Thirdly, the flow of search strategy followed the PRISMA, which is good.
I'll put that every day. Is it not my?
The flow of search strategy follows the PRISMA, which we think is appropriate. And with regards to assessment of risk bias and quality of evidence, they use the Cochrane tool for randomized control trial, which is good, because like I mentioned initially, the 37 studies were ROCTs, And the next, they conducted sensitivity analysis. And in doing so, they excluded trials only reported as abstract. They excluded trials published before 2000 and so forth and so forth. We also think the tables are okay as they contain all the parameters required to make a good judgment. The forest plot was okay. They gave a picture of what each study is like and what each study is contributing in the context of all of them.
Okay.
In a nutshell, for the forex,
yeah,
I'm not done. Yeah, in a nutshell, regarding the forex plot, the study is rigorous enough. The point estimate and the confidence interval are close, with no cases, with number of cases evaluated, and this is a good pointer. Subgroup analysis was done. They had a protocol registered in Prospero. The heterogeneity was assessed, and the values were mentioned. And in conclusion, for what they did correctly, the study reflected the findings from the the conclusion reflected the findings from the meta analysis. And just a quick one, what we think was not clear were two things. One, the search term, that's the PICO, the outcome was not reflected in the search term. And secondly, we're not clear if they included fixed effect model or not, because there was a section that was not clear if fixed effect model was incorporated in the work or not. I think that is primarily what we looked at. Thank you.
Okay, thank you very much, Group 2. In essence, you you have some confidence on this paper that it was
yes.
done well, and I agree with you. So this is an example of how we can improve our processes, starting with formulating your question and registering the protocol. Then their search was not comprehensive enough. I think that is the downside of this. Yeah, they have used 3 databases, but there are many others that they would have used as well. Okay, Group 3.
Thank you very much. This is possibly I'll be presenting from Group 3. The research question for our article was to determine whether antibiotic treatment leads to improvement in growth in prepubertal children in low and middle income countries. And from the conclusion, it was stated that there is a significant relationship that growth is actually being promoted as a result of the antibiotic use, based on the conclusion. Now, in detail, we reach a conclusion that the research question answers for population intervention and outcome, with the children between the age of 1 and 12 years being the population, and intervention being the antibiotic treatment, and outcome being the growth of the children. The protocol for this review was indicated to be registered, and we found out that the literature search was, however, very comprehensive, with a database search of Medline, Embase, Scopus, and Cochrane. And this search itself spanned from till December 2013. So all control trial that have been published, unpublished, or reported up till December 2013 was included in this literature review. Quality assessment was done using an instrument adapted from Cochrane Handbook, and we must applaud the authors because they didn't give room for bias. They had a lot of professionals in this study. They had professional librarians developing the search string. They had 2 independent reviewers for data extraction. And however, there was no mention of an arbitrator because in case of discrepancies, there was a consensus and it was resolved. And also, a random effects model was used, and it was identified that this was because of the heterogeneity of the studies. And this was explored using the weighted meta-regression and subgroup meta-analysis. One major, I wouldn't say it's major, thing that we found that could not be as significant as we thought is the data pulled, the articles pulled were quite a lot from one of the limitations they mentioned. So there was no mention of a subgroup analysis of which of these antibiotics treatments actually have effects on growth. There was no mention of which treatment, in what doses, and what particular drug have effects on growth monitoring. But overall, we would say this is a very comprehensive article, a very comprehensive analysis and review, and add a lot of professionals and experts on this work, making it informative and also very concise.
Okay, thank you very much, Group 3. So it looks like you have, on average, good impression of this paper.
Yes.
What journal was it published?
BMJ.
BMJ, yeah. One thing you observe, I need to mention this, I didn't state it from the beginning. Systematic review originated, we will say officially, from the UK. It originated from the UK. And the man called Cochrane, from whose this organization was built, was one who started pushing this forward. And that is why if you send your papers to British journals, BMJ, the Lancet papers, and other British journals, they are more critical than American journals, because the tradition of systematic reviews and meta-analysis have not, of course, Americans do it, but it has not taken so much root there as it is in the UK. So JAMA journals and some other American-based journals, you see that they are, of course, the rigor that the British journals will require is not as the American journals will require. That is what happens there. But BMJ is a very big proponent of systematic reviews and meta-analysis. So that is why they have experts who can really assess this. Anyway, you have good impression of this. One thing you pointed out that I want to also clarify is the arbitrator. You said they didn't have an arbitrator. Yes, arbitrator can be on standby, or the authors can, that are doing the review, can already have consensus between them. So there's no fight. They understand themselves quite well and they easily agree on these issues. So in that case, there may not be need for an arbitrator. Oh God, thank you very much for this. I see that the group so far presented, you have some insight on what you should look at for when you have a systematic review paper to critique it and find out some things that have not been done well. Okay, let's go to group 4.
Good morning, sir.
Good morning.
Group 4, the title of our paper was Long-Term Risk and Benefits Associated with Cesarean Delivery for Mother, Baby, and Subsequent Pregnancies, Systematic Review and Meta-Analysis. The objective of this paper was to describe the long-term risk and benefits of cesarean delivery for mothers, baby, and subsequent pregnancies. The paper itself was published in PLOS Medicine, and the method used was Medline, Embase, Cochrane, and Cumulative Index to Nursing and Allied Health Literature, CNAL database were used. It was a study that randomized controlled trials was used, and a large database was involved. 2 assessors were used to screen the data. We had an abstract of 30,322 abstracts. We found out that the paper was a strong one. Prospero was also used. There was the use of 2 library assistants in reviewing this huge number of database, which is 30,327 for a 3-year period from 2014 to 2017. We found out that it was the paper was strong. But our only recommendation is that we think that the paper was done in an area of people who were more rich, let's put it, a high income community. And we think that in terms of generalization, it would not be right for us to generalize based on this, since we have people from low income communities or countries who were not involved in the study. It was a strong paper. Like I said, the methods that were used were properly done. So based on the time that we had, that's the much I can say for
now. What approach to meta-analysis did they use?
The
random effects or fixed effects?
No, random effects.
Random effects.
Yes.
Yeah, I couldn't understand when you said that the generalizability, the people in the study were from high income communities. What does that mean? Is it the people recruited in the primary studies or the investigators?
The people recruited in the primary studies, sir.
Okay, so the systematic review focus on high income countries.
Yes, sir.
Okay, so it means that yeah, the results can be generalized only to high income society. Yeah, okay. So your issue is that that evidence should have been done in a way that is also relevant to low income
countries. Yes, sir.
Yes, sir. Okay, yeah, that is good. And you mentioned that you registered the protocol.
Yes, sir.
So overall, you think that this study is excellent?
Yes, sir.
Okay, thank you very much. Group 5.
Okay, our paper was on elder abuse prevalence in community settings, and they wanted to synthesize data on the prevalence of elder abuse in community settings across the world. At the end of the day, they had an overall prevalence rate of 15.7% of elder abuse globally. There was a prior protocol they registered with Prospero. The search was comprehensive. They searched 14 databases and really other web-based platforms like Google Search. They also contacted experts in the field. And so we would say that their search was comprehensive. They ended up with 38,544. However, the papers that were included in their study was only 52. And we think that this number is a little bit low. The screening was done. Yes, it was done properly. The review, the extraction was done by 2 people. And then the review were, in fact, I would in overall, I would say that not one reviewer did one thing at a point in time. They had a risk of bias too, which for them, they think it was standardized, but they did not indicate whether it was adapted from something like the EP, HPP, or other well-recognized institutions that have developed those tools, or whether they did it themselves. Meta-analysis, they justified why they used meta-analysis, but they did not indicate whether they went for REMA or they went for FEMA. With respect to the use of I-square, they indicated that yes, they conducted a heterogeneity test, but in their forest plot, there wasn't any information on I-square and other important information. They only presented the points estimates and then the overall estimate. With respect to the other features that we have observed that we think that they could have done better is with regards to justification for why they concentrated on community settings. And we think that did not come out well. In addition, with respect to their data extraction, the categories they focus on did not include individuals. I mean, the abusers, the category of abusers who were abusing our elderly people in the community. That did not also come out clearly. With respect to their findings, we would say that it is reliable. However, we would have wished if they had had more than 52 articles to draw their conclusion on. There was this strength of them following the protocol and would commend them for that, sorry. And I think it was a good paper as a way of learning about systematic review and meta-analysis, just that they did not indicate whether REMA or FEMA, and so it is a very big weakness. Thank you.
Thank you very much. That was really a good one for group 4. Yeah, group 5. I think what you have done, the editors will be happy and they will be contacting you more and more to review for them because you have taken a very close look at this. But overall, you have a good impression about the paper, and still you noted there are rooms for improvement of things they would have done. And clearly, the experience you have gained from this course, I think, is showing in this. What journal was that published?
Lancet.
Lancet, yes. Lancet. So you can also see that Lancet missed some aspects of this. One thing is that that we shouldn't assume that everybody understands what the processes are in doing systematic reviews. And so because of that, some editors may miss it. Some reviewers may also miss some of these issues that they appear trivial, but they're actually important, especially when you say they performed heterogeneity test, but there was no indication of that at least in the forest plot. And not giving clear picture of what they have used in doing the meta-analysis. Yeah, David, you're raising your hand.
You finished. Yeah, I thought you finished and I asked my question.
Yeah, go ahead.
Oh, yeah, I was surprised that I wish we can get access to some of the papers also that other groups have looked at. That did not mention the method of the meta-analysis and it's published in Lancet?
Yeah.
Yes.
Yes, they didn't mention.
Which year was it published?
2015.
2015, okay. Okay. That was just my shock, yeah.
Yeah, and that is the point I was making, that these things can get through One, depending on the editor who is looking at it, and the reviewers. The reviewers may be expert in the field, may not be expert in the methods of meta-analysis and systematic review. So through that, this can get through the review process. But if it comes to you, if this paper comes to you, I am happy that what you have done now, Lancet will be happy that you have taken a closer look at these papers, and I think that is one thing we want to achieve in this course, and spread it as much as possible, so that for you doing your own work and for you reviewing for the journals, you're able to pick out some of this, because the ultimate goal is for us to enhance the research process so that the evidence generated, we can have confidence in that and use it in the appropriate way to reach decisions that they are made for. Okay, the last group, group 6.
Prof, before you go to the last group, I have a comment. Godfrey, the tools they use for the quality assurance and the others, is it necessary it appears in the journal, or that is not necessary? Because this was not included. So I was also thinking that that is something which should appear.
Well, it's not necessary that you include it in your paper. If you have used the tools that are available there, you can just make a reference that we use this tool. But if you remember, Josephine was asking in the morning, some of these tools, if they have not included some aspect that you would have loved to evaluate in the studies, and I said you can integrate your own aspects there in the tool, and when you do that, you can include the tool as a supplementary file. The tool you have adapted, or you have made some input into, you can include that and mention that we included some questions in that case. But otherwise, you can just reference the tool that we use this tool, and you give the reference, and that is fine.
Okay, thank you.
Okay, last group. Let's see what you have. And yes, sorry, and yes, David, you can have access to those papers in the Dropbox. I think you can have access to other groups
Great.
folder.
Great.
Yeah.
Great. Okay. This is group 6. Some of the observations that were made by group 5 are actually recurring. Apparently, I think the paper is from the same journal, Lancet, especially in the aspect of the methodology. But I will just mention a few things that are a bit more, different. Clearly, this paper that we examined, the title was Physical Distancing, Face Masks, and Eye Protection to Prevent Person-to-Person Transmission of SARS-CoV-2 and COVID-19, a systematic review and meta-analysis. The protocol was clear. They registered with Prospero. Of course, there was comprehensive search of particular databases. A manual searches also was done. Interestingly, including studies that are possibly still being undergoing review, including abstracts, epicenter living systematic map, and clinical trials of the WHO. However, that is about the screening of the paper. They use multiple stages, which was clearly stated. WHO confirmed, the WHO confirmed protocol of doing that. Quality appraisal was spot on. And it was particular in the evaluation of risk, the risk of bias. They adopted the Newcastle Ottawa scale. But again, of course, just like it was pointed in group 5, the REMA, there was no justification, nothing to show for that, on how that was done. Heterogeneity was quantified. and was explored also by this paper. However, we also realized that literature search was comprehensive. It examined all studies, like I stated earlier, up till the month of May of this year, 2020. Then I found something that looks to me conflicting, but maybe after we finish the group presentation, I may ask the question. It also shows that the authors were not fully balanced, in my view. They were all of a particular route. There were no librarians and, you know, non-clinicians, but maybe health, allied health, you know, that didn't show up in it. Then of all that was also screened, only 172 studies, and it was stated from 6 continents. But then a careful look at the countries that were adopted for these studies, clearly Africa, South America there was no single paper, you know, that came from those regions. So in my view, in our view, generalization of what the outcome of the paper is may be a bit distorted, so to say. Then of course, the paper was deficient because case series data was they just use estimates. They did not systematically rate risk of bias to these data that they use. And then of course, of the 72 studies, only 66 were examined again. So it was further screened down to 66. Yes, I think that is it from group 6. Thank you.
Okay, thank you very much, group 6, for looking in detail into this study. There is confidence in this. I think you have, and also highlighted some of the limitations. Your paper is quite peculiar because it's a paper that relates to the current pandemic we have. And believe me, thousands of papers have been published with regards to this COVID-19. And most journals nowadays are looking for such papers, COVID-19 related papers, even journals that are not looking at respiratory infections as such. And so because of what is happening nowadays, there is a risk that many things will be published across the journals that are rubbish. This paper, I wouldn't say is in that category, but just to be aware that because of the trend of things happening, a lot of things are being published. I think there are some investigations also found that some of the data some of the authors have used in some investigations during this period are fabricated. So be aware of that. But one thing is that on the other side, many of the journals in publishing studies based on the pandemic we have to an extent also relaxed their strict measures in certain aspects because they want, we don't, this is the first time we're having this kind of this type of strain of this coronavirus. And so there is interest to understand as much as possible. So whatever data we have, let's get it out there. So we run a risk of people trying to manipulate the system. But what the authors have done in the paper, given the time they have done this, I think the journal that published Lancet will understand that really let's publish it. There is room for improvement in going forward, but let's get this out. with regards to the composition of the expertise they have included in this study, one thing you have to know is that, of course, I mentioned that you should compose a team of information experts, subject experts, and methodological experts. I have worked with clinicians who are methodologists themselves. There are many clinicians who are really very good statisticians. They know what to do. There are many clinicians who are methodologists in terms of doing the systematic reviews, so they don't need to really bring in an information expert or bring a methodology, because they already know how to do these things. So the point I want to make here is that when I say composition of your team, not necessarily that you go and bring a librarian. If you have that expert already in your group because you have developed it, then you make use of that. You don't need to go if I want to do a systematic review today, I can do from the beginning to the end without looking for a librarian, because I know how to do the searches. I know how to develop sometimes if I run into some challenges, I can consult them. But this is how it happens in many cases. Then you also mentioned the fact that the studies from the developing countries were not included, and it affects generalizability. Of course, that is the case. But you have to also note that this the trend of this pandemic got to many of the developing countries later than they did in other parts of the world. And I guess this study you reviewed here was published before many of the developing countries had this. So there wouldn't have been any.
It was published June 1 this year.
June 1, yeah, and that is also the point that even if it has reached the developing countries at that time, you need studies to come out of there before you can include those studies. So if nothing has been done from those regions, then it means that they can't include studies from those areas. So you have to deal with what you have. And so some of these things affect, but the authors still need to acknowledge the fact that in generalizing our results, the focus will be on where we have received the studies. Those contexts that are not represented cannot have these results applied to them. Okay, thank you everyone and every group for the participation in this activity. The goal of this activity is for you to have a feel of what is happening in the publishing arena with regards to what we have covered this week, so that you, when you pick up a systematic review and meta-analysis paper, you have a critical mind to read it. It is not about the journal where it is published. It is about following the methods that are used to do this, and we have covered these methods, and you have to look out for these things, how the authors have done and reported their studies. So please also go back to the Dropbox folder where we have there are two papers I have given there that have described how you can critique a systematic review paper. You can continue to read those papers at your own free time, so that you can enhance your knowledge of having a systematic review, just to read it for yourself or reviewing for a journal. But I think from what I can see, you are getting grasp of what to look out for. That will show that a good job was done. So thank you very much. I have got the feedback that some of you are still working in your group project. The next session, I will start it at 12 o'clock, my own time. So what I want to do now is to send you back to your groups so that you can continue aspects where you stopped yesterday, so that this afternoon, when you go back to your group, you advance. So that is why I shortened the time for this critical assessment of the papers to give you sufficient time, because I want you to finish that project so that tomorrow you have confidence to present what you have done, because that is my own goal, that you go through these processes and be able to see that you can design your own semantic review and carry it out. So let's come back in 5 minutes. By that time, I would have assigned you to your own groups and send you to your groups so that you can continue from where you stopped, unless somebody has a question at this time. Who has joined? Who is there? Hello? Which group are you? Hello? Okay, welcome back, everyone. I hope you have been able to progress a little bit with your work. We will continue in the afternoon with this. And so I have put here what is expected of you, of the groups tomorrow. So the expectation is that from what you have done, you should prepare a 10-minute PowerPoint presentation to describe what you have done, and that is how you arrive at your question, the question you have addressed, then the different aspects you have covered as we have we have gone through in this class. So that is what expected. It should be 10 minutes. You are not required. You can see that here it was in this place. It was the writing report. So this is changed to having a presentation in class tomorrow. So please restrict it to 10 minutes, and then we will all have opportunity to discuss what you have done. So this afternoon, you go back to your group once we have finished the afternoon session, and then tomorrow morning, you also begin with your group. So when we meet 9 o'clock tomorrow, we'll have some instructions. Then you go to your group, and you go to your group tomorrow morning to finalize it and prepare your presentation. And that will be it. And we'll come back here in the afternoon after lunch to listen to the presentations. Okay, is there any burning questions so far you want us to? Okay, otherwise.
Right, I have a question.
Yes,
in our this thing, our design will have an effect of a prenatal maternal intake of zinc on autistic child. So when we're trying to extract our or some of our literature review, we got a paper that it didn't mention maternal, that is as per mother. Can we are just wondering, can this paper, can we include it and, for the, but the argument would be like the paper is not high weighted.
No, yeah, I mean, the papers you include must be the papers that specifically address your question. Sometimes you see papers that may be very attractive, but if they don't fit to your question, then you have to remove them regardless of what they have done, because you have to restrict yourself to the question and the criteria you have used, you have stated.
So does it mean all the criteria must be there? Talk about the maternal, the zinc, and the autistic child.
Yeah, all the criteria you have stated must be met. Must be met.
Okay.
Mm-hmm.
Okay. Thank you.
Okay. Now let's move on to the topics of today. Yesterday, one of the questions was if, for instance, the systematic reviews we have done, people are doing, are also having their own problems. How can we also identify and appraise these systematic reviews? That was an important question. And the first day I mentioned the pyramid of, or the pyramid describing the hierarchy of evidence in reaching decision. I indicated that umbrella reviews are now occupying the top there now. So this is what umbrella reviews are. And I will go through briefly of this. This is a method that is now being becoming popular. This was developed around 10 or 12 years ago. It's becoming popular. It's not very common now, but it's increasing. And there are some motivations for this, doing this umbrella review. And one of them is what we have highlighted, the inadequacy or poor quality of many systematic reviews being done there. But the important motivation for this is that interventions we have, let's say, for instance, vitamin D. Vitamin D, I think it has been the vitamin, the most popular vitamin in the last 2 decades or so. And people have linked it to several outcomes, clinical outcomes, public health outcomes. So vitamin D becomes so important. In this part of the world I am here, now we are in the summer and the sun is coming, and we have this for 2-3 months, and after that the sun impact of the sun reduces. We get into the winter, and so we just go. So to get this vitamin D into our system, we use vitamin D supplements, and many people who don't use vitamin D supplements eventually can really become critically ill. Vitamin D has been linked to have impact on the immune system and can influence other outcomes. And so the argument is that the way we have usually evaluated medical interventions, looking at the impact of a particular intervention on a particular outcome, may give us a myopic view of that intervention. So the better way of doing this may be to look at all the outcomes that this intervention are proposed to impact, bring them all together. When we bring all these outcomes together, we'll be able to see which outcomes does this intervention, for instance, vitamin D, which outcomes is vitamin D influencing? Which outcomes is vitamin D influencing positively? Which outcomes is vitamin D influencing negatively? And which outcomes is vitamin D not actually playing any role? Now, when we do our systematic review, as we have gone through this week, and do our meta-analysis, what we do is that in most cases, we are looking at the impact of an intervention on one outcome or few outcomes. So the proponents of umbrella review are arguing that that actually will provide us a myopic view or limited picture of the role of this intervention on human health. The best approach will be to bring all this evidence that have been done, and we can appraise them. And in so doing, we'll have a clearer picture, not only for the sake of our knowledge, but also for decision making. For instance, the physician would know that, okay, even though they have said vitamin D is important for health outcomes, there are outcomes that vitamin D does not have any role, so we wouldn't recommend people to take it because there's no impact. Or if our decisions concern policymakers will also be able to know where to tailor the resources appropriately. So umbrella reviews are used to bring together and synthesize already conducted systematic reviews or meta-analysis. They are not used to synthesize primary studies. They are used to synthesize the systematic reviews. Another motivation is that so far, since the origin of systematic reviews and meta-analysis, many of those have been done on a particular topic or with regards to a particular intervention. There are many systematic reviews, and people are doing it in different ways. And you can see that from our critique of the systematic reviews today, you can see that people are doing certain things that are not the right thing to do. So that a systematic review or meta-analysis have been done does not mean that it provides sufficient conclusion of that topic. There may be some biases in the process. For instance, a systematic review is conducted with only one person, or the screening and data extraction not done in parallel by two people and decide. So because of this, we need to make appraisal of the systematic reviews themselves. And in doing this, it helps us to progress science, because people are doing many things that are wrong. For instance, a few years ago, I had a student who did a systematic review and meta-analysis. And she studied this acid reflux medications that people take. Particularly, this is a common thing during pregnancy, and see whether the intake of these acid reflux medications are influencing the development of asthma in children if women take these medications during pregnancy. So she did this for her master thesis, and then she decided to publish it. And so we walked through this, and she got these studies, few studies anyway, but some of them use hazard ratio, some calculated odds ratio, some calculated risk ratios. Hazard ratios are different from risk ratio and odds ratio, because in hazard ratio, you are estimating the time to an event. the risk ratio estimating the risk of that outcome, while hazard ratio estimating the time to development of that outcome. So they are not exactly the same, because in hazard ratio, you have the aspect of time you have included. The odds ratio, on the other hand, when the disease is rare, epidemiologically, we know that the odds ratio can closely estimate the risk ratio when the condition is that when the disease is rare. So to a great extent, you can convert the odds ratio to risk ratio. So what we did was, for those, because we know that this disease is rare, and we converted the odds ratios to the risk ratio. And for that, we were able to bring together the studies that have estimated odds ratios and risk ratios together, because we converted the odds ratios to risk ratio. And so we published this study. And then a year after that, I got, because I subscribed to the titles of some of these journals, I got one paper that came on the same topic we published a year before. And I checked it, and that paper carried an editorial from that journal. This pediatrics. Pediatrics is one of the top pediatric journals in the world. So I checked it, and the editorial came from a colleague, two colleagues of mine I knew. And so I looked at this paper and discovered that they have done exactly the same thing we did. They included the same studies we included. But one thing that was surprising was that in their own analysis, they brought together the odds ratios, the risk ratios, and the hazard ratios, and analyzed all of them as if they were the same estimates. They did no conversion of the odds ratios to risk ratios, and in fact combined the hazard ratios. And this journal published it, not only publishing it, but wrote an editorial in that. So I remember going to a meeting, and I met my colleagues who wrote this editorial. I said, I saw this editorial on this paper. And they said, yes, the editor asked us to write editorial because we reviewed it. I said, wow. So when you were doing that, you didn't see that we published a paper before. And they said, yes, really, we saw this when we were writing the editorial. When we went to the literature to search, we saw that you have published a paper on this. So I described to them the problem in that study they wrote it. But of course, they are not experienced in doing systematic reviews and meta-analysis, and they were really surprised and ashamed that that could go through. But the point here is that there are so many things published there that are done in the wrong way. And so the best way to deal with this is to conduct umbrella reviews that will now critically appraise these studies and put them in the way or where they belong. So through umbrella reviews, we can appraise systematic reviews and give them quality statement as well. That is what we do here. So I have mentioned this, that integration of evidence from all systematic reviews and meta-analysis on the intervention will give us a more comprehensive picture. So bringing all outcomes together will give us more comprehensive picture. And this will help us to understand the uncertainty and provide decision makers with the most robust evidence there to make decisions. So in essence, this is what we're trying to do. So we go like we do, search the literature. So if this is an intervention, let's say we are looking at breastfeeding, and we have outcomes that breastfeeding influences. So instead of doing this one by one, as we do in the normal systematic reviews and meta-analysis, what we'll do in umbrella review is we focus on this breastfeeding as an intervention, and we consider all outcomes that have been investigated, all outcomes that have been investigated. It could be the other way around, that we are interested in an outcome and we want to look at the influence of all interventions that are there that we know can influence this outcome. So it could be the other way. So an intervention on all outcomes it influences, or an outcome on all interventions that can influence that outcome. Any questions so far? Okay. Yeah, when we bring all this together, we summarize the magnitude and direction of effects. We will know where the evidence is positive, is strong, is negative, is weak, there's no impact. And so we have the clear picture, as you will see as you go through this. We evaluate significance of reported effects, assess potential biases across the studies, and still have in mind that what we are doing here is that we are looking at systematic reviews and meta-analysis and not on the primary studies as such. So we can then identify most or least robust convincing evidence on the topic. Yeah, I mentioned this and how this has increased. This was a journal in 2018, how this has increased. Not so many studies published, less than 35 studies as at 2008 have been published that have done umbrella reviews. So they are still coming. How do we do it? The same approach we use in our systematic review. We define the question, we conduct our searches, we screen the studies, but we are focusing on systematic reviews and meta-analysis. And because the umbrella review is so much interested in quantitative estimates, there is so much focus on meta-analysis. But when we do the search, we are searching only for systematic reviews and meta-analysis. So if you search PubMed, you need to put the filter that you're interested in, systematic reviews and meta-analysis. So once we have done screening, we extract the data as we do, and then we include this systematic reviews and meta-analysis. And what happens is that we want to get the data from this systematic reviews and meta-analysis. Sometimes the systematic reviews and meta-analysis do not report all that we need from them from the primary studies. If primary studies, if the systematic reviews are lacking in some of the estimate from the primary studies, of course, we go to the primary studies to get this information. So this can be demanding. This can be demanding. Then we need to appraise the quality of the systematic reviews, not the primary studies. We here appraise the quality of the systematic reviews, not the primary studies. And this is the tool, AMSTAR, that is used to appraise the quality of the systematic reviews. So if you go here, you'll find this tool. And so what do we do? There are lots of statistical approaches that are used, and the goal is that we want to synthesize the evidence. I wouldn't go into details of this, but there are a lot of statistical computations that are used here, and the goal of using this is to make an evidence statement. And once we are making this evidence statement, we are not focusing on the evidence at the systematic review level. We are now synthesizing the evidence on the outcome level. If I go back here to show you, so once we have done this and we are going to make the evidence statement using the statistical methods, what we do, we want to understand the effect of breastfeeding on maternal asthma. What is it? Is it convincing evidence we have on this or not convincing evidence? And we'll do the same for each outcome. But what happens is that the quality appraisal we do and all this we have done, we feed into making this evidence statement. So here there's a suggestion of the categories of evidence statement we can make. They call it class 1, class 2, class 3, class 4. And here class 1 is where we have the convincing evidence. And there are different parameters that are used to make that decision, which come from reanalysis we do on those studies. We do a reanalysis and incorporate these parameters that are used to make this evidence. And so the first one is convincing. Any question? Okay, the second one is that the evidence is highly suggestive if the evidence meets the criteria here. The third one is suggestive. The fourth one is that the evidence is weak. And the last one is non-significant, meaning that it can be thrown to the dustbin. Okay, so this is how we do this. I'll show you examples of how this has been reported in some previous umbrella reviews. And this study is looking at the effect of coffee consumption on health. And this has been a controversial issue, of course. Recommendation of coffee is controversial. Sometimes people keep taking this because they are addicted to it. So this umbrella review looked at the effect of coffee consumption. And what they have done here is that they have looked at all outcomes that have been investigated in relation to coffee consumption. And so on this forest plot, what they have done is that they presented the 10 most harmful outcomes that coffee affects and 10 most beneficial outcomes. They said they found that coffee beneficially affects. So this is what they have done. And you see here, when we do our own meta-analysis, what we have done here is that we have the studies here. But because the umbrella review is not synthesizing the evidence at the study level, it's synthesizing the evidence on the outcome level. So the question is, with regards to acute leukemia in childhood, what is the impact of coffee? And evidence is given there. And you can see these indexes or parameters that are used to judge the evidence are also included in these areas, in this figure. And it does this for each of the outcomes. This is another way. This study also looked at vitamin D and multiple health outcomes. So looks at vitamin D and all outcomes that have been linked to vitamin D. And it has presented the outcome. This is not presented as.
Sorry, can I ask you a question, please?
Yes, please. Go ahead. I can't hear you. Okay, it seems your line is so bad, but I will continue.
Yeah, you sorry, I want to take you back to, yeah.
Yeah, something is wrong. But anyway, what I was saying is that this one has not presented this as a figure, but as a table. and you can see the outcomes, how they have measured this vitamin D, and the metrics they have used in calculating the estimate, the number of studies included in the original meta-analysis that has looked at this outcome previously, the number of events when you put all the events in this 6 meta-analysis together, and the total number of people when you put all the people in this meta-analysis together, and then the relative risk, and then they reanalyze to calculate all this so that they can derive the index they have used here. This is not so clear, but here they presented the outcomes as forest plot as well here. Okay, so this is the just a short introduction of umbrella reviews. Currently, one of my doctoral students is doing that. It's really demanding, but what happens is that this is the highest level of evidence that we can have now to make decisions. We have some topics that are there we would like to do that in the pipeline. If you want to learn this method and you want to join, please get in touch with me. The only thing I have to say that this is very demanding. It requires time, it requires dedication. But if you think you want to learn this, you want to contribute, get in touch. Some have gotten in touch with me when I said on Monday or so. Get in touch, and after this course, we can initiate discussions, and I can guide you, and my team here that has some experience can also guide you in getting this through. It takes time to deal with these issues, but it's not that they cannot be done. I see people are publishing it. If you go to the literature, this kind of evidence synthesis are published in the top journals because they are interested in this type. BMJ, Lancet, that is where some of these kind of reports are published. So if you're interested, just drop me an email and mention umbrella review you want to learn, and then we can take it from there. So I wouldn't get too much detail into this because there are other intricacies that we need to go through, but just to introduce you on what is happening on this area. Any question?
Yeah, question.
Yeah, your line is so bad.
In summary, you're saying, is it bad?
Yeah, I can hear you now.
Is it still bad? So with respect to umbrella reviews, that we're looking at specific outcome as shown by the systematic reviews.
Yeah.
But that is the part I want to get cleared. We're looking at just specific outcomes. We say we're not looking at individual papers.
No, we're looking at individual papers, but the point I'm making is that the synthesis we make, we're making the synthesis focusing on the outcomes. So if we want to see the impact of an intervention on the outcomes, the question umbrella review is asking is that what is the level of evidence with regards to this outcome? If, for instance, you're looking at vitamin D on prostate cancer, on malaria, on HIV, umbrella review is asking the question based on the reviews we have now. What is the status of the evidence for these outcomes? For prostate cancer, is it a convincing evidence we have? For malaria, is it a convincing evidence? So by the time we finish the umbrella review, we're able to give the evidence grading for each outcome so that those who make decision will know we do not have sufficient evidence to make decision on this outcome. We have sufficient evidence for this outcome. That can also help in distributing our resources.
Okay, please, I also have a question.
Yeah.
With regards to the parameters for determining whether it is suggestive, highly suggestive, and all those kind of things, I saw cases greater than 1,000.
Yeah.
Yes. So with these cases, are you referring to the cases? Please, can you move to
Yeah, I'm here.
Can we move to the next slide so that I use it as an example? The one on yes, coffee consumption. No, there was one with people's that's indicated the number of cases. I think it's
yeah.
Okay, so with 1,000, is it referring to every systematic review should have greater than 1,000? Every systematic review included in the umbrella review should have more than 1,000 cases for you to say that maybe it is highly suggestive or convincing, or all together should be more than all the umbrella systematic reviews together, all the cases together should be more than 1,000.
Yeah, so this evidence grading, it means that for each of the outcomes, this is one of the criteria you use. The point here is that they want to ensure that we have sufficient power to make this kind of grading on this outcome. So for each outcome in the systematic review, the expectation is that to have convincing evidence, there should be more than 1,000 outcomes. And of course, there are other indicators that you have here that you need to consider. So this convincing evidence will meet this criteria they have stated here. Highly convincing also has its own criteria that it needs to meet. Yes, but yes, this indicates the cases of the outcome when you put all the studies together. Like here, you see that they have indicated the cases for each of the outcomes here, as well as the total number of people across the studies.
Thank you.
Okay, any more? Okay, if not, we'll go for our lunch break, and please let's come back at 1:40 Central European time, and that is Nigerian time 12:40. Please adjust that to your own local time, and then we'll continue from there. Next, we'll be doing individual patient data meta-analysis. Thank you, and see you soon. Okay, welcome back. I hope you are now refreshed, having your lunch. So we will continue. And this afternoon, there are two issues we will cover this afternoon before we go back to our group work. Okay, so the first thing we will be covering is what we know as individual patient data meta-analysis. Okay, good. So you see what we have done so far. What we have done is that we have been dealing with data we have extracted from published papers. We are dealing with data we have extracted from published papers. But this is limited in many aspects. One, as I've explained, sometimes some of the information you require in the papers are not available. And even when you make efforts to contact the authors, many times you fail in doing that. And that gives a problem so that we don't get what we set out to get. But still, the data from published papers also limited because, for instance, in some cases, if we are looking at observational studies, we'll include estimates that the studies have, for instance, adjusted based on different factors. So the consistency of factors included and adjusted in the studies is problematic across studies included. So these factors really limit our opportunity to do things perfectly the way we would have done them. So that brings us to what we call individual patient data meta-analysis. And this is in a situation where we are dealing with each study we're including in the meta-analysis. We have the data for each individual in the study. Let's say you have 5 studies. Instead of using the odds ratio or the numbers from the studies, we have the individual patient data. We have the data on confounders. We have data on whatever we're interested in. So this gives us opportunity to do different things. And for instance, as I mentioned, with regards to adjustment for confounding factors, because we have the individual data, we can ensure that we're adjusting for the same confounders. Sometimes, like I mentioned in the previous session, that in the study this student of mine did, we converted the odds ratio to the risk ratio, because the studies have calculated different estimate. We couldn't include the studies that have calculated the hazard ratio because that is not equivalent to risk ratio or odds ratio. But if you have the individual level data for all the studies, we are able to ensure that we have the same estimate, the same types of estimates. We can have the same hazard ratio, or if you want it in risk ratio, we can have all the studies in the same metrics. So that is the level of the individual patient meta-analysis, which is said to be the gold standard of meta-analysis. Because we teach, we can do all that we set out to do. Okay. The problem, as you will see here, is that this can be time-consuming, resource-intensive, can be frustrating, can be difficult, but it is worth doing it. When we do it, we have central collection of all the studies, or the data from all the studies. We can check for consistency. We can check for whatever is possible there to make our estimate, and that is quite important. So individual patient meta-analysis is helpful when it is possible. Okay, I mentioned this. The benefits are we have standardized way of measuring our parameters, analyzing, defining our exposures. Yes, David, you have a question?
Right. I was just wondering. We did something. I don't know if we, if it was this, but our senior author suggested this. We had a debate over that. One of our papers where we used DHS as a primary data and did meta-analysis. We call it individual participant meta-analysis. I don't know whether I fit into the individual participant because we had, of course, we have the individual data from each country, and then so it wasn't like meta-analysis from a study, but meta-analysis from the raw data. Is it correct to call it so, individual participants?
Well, let me finish so you can see what is here, whether it's what you did.
Okay.
Because there are steps to implement this. Okay. I've not checked that paper to know what you did, but you can check and see whether what I'm explaining here fits into what you have done.
Okay, great.
Yeah, yeah. So when you have the individual participant data for all studies, you can standardize your exposures. That is one of the problems you have if you have data from published sources, from published studies. One of the problems is that the parameters in the studies are not standardized. For instance, you may have one study that has given 8 categories, and they can give it in 5-year interval. Say 0 to 5, 6 to 10, 11 to 14, 15, 16, and like that. Sometimes it can be 10-year interval. Sometimes some studies can employ different categories, say 0 to 20, 0 to 18, and so on and so forth. So the standardization of the exposure or outcome is problematic. And so you find it difficult to do that when you have aggregate data from published sources. But if you have the individual level for each study, you can standardize your measurements. Sometimes you may see that a cohort study has, for instance, followed people and made estimate. This particular study you have collected from the literature has looked at maybe the onset of the disease after 2 years. Some have looked at after 5 years. Some have looked at after 10 years. And that also becomes problematic because it's not standardized. These are different time points. And if the disease is something that is sensitive to time, then we have problem. But if you have individual level data, you are able to standardize things like follow-up time. You can standardize confounders. So the essence here is that with the individual patient data, you are able to use common metrics, common parameters, common categorization. And that raises our confidence that bias, perhaps that may be due to differences in measurement, is minimized. Excuse me. Okay, so if we have this, it allows us to have more detailed data checking to see where there could be a problem, and this will enhance our quality of what we do. Sometimes you may have missing data in the published studies, and you don't know how to deal with this because the authors have not reported it or how they have dealt with it. So okay, but with individual data, you can now see how the missing in the data is, what could be causing the missing, and you can use methods that are there to perhaps impute those missing there. You can deal with things like interactions. You can evaluate this within the study. You can do analysis that are really suitable for those studies. That some studies have done it. For instance, they have intention to treat analysis type for clinical trials. Sometimes people do what they call by protocol. And if you get studies that have used intention to treat and studies that have a protocol from the published literature, it's difficult to combine because these are different assumptions. But when you have individual data, you are able to deal with this in the same way. Ensure that all studies are analyzed using intention to treat approach, or if you want to do it by protocol. With individual patient data, we are able to undertake subgroup analysis in the right way. Because we have all the data, so we're able to confidently group the participants in the right way. This will also increase statistical power when we have patient unit data rather than study unit data. Because when we do the combined estimate based on the literature, where we have only the aggregate estimate, we are looking at number of studies, but here we can increase power because we have the patients there. One other advantage of this is that when you are doing individual patient data meta-analysis, the authors or the investigators across the different studies are usually involved in the process. And once that happens, it gives more impact to the study. Most often when you have individual patient data meta-analysis, it's very impactful, and the top journals are interested in publishing this. Okay, how do you do it? In reality, you contact the investigators. Once you have defined your question and you know what you want to do, you contact the investigators. Perhaps you search the literature and you contact the investigators of the studies you have found to involve them in this project. We want to do individual patient meta-analysis. We have identified your study and it's relevant. Can we schedule meetings to discuss and so that you can contribute your data to this? Then you take it from there, and sometimes you get positive answers, sometimes you don't get positive answers. One thing here is that those studies that you don't get positive answers, you also reflect them when you do publication bias analysis, because you have not included all the studies there. So once the authors have agreed to collaborate, you collect all the data. So they will send you the data of their studies and you collect everything in a central place. You check the data for consistency. You categorize consistently the variables. You make your outcomes in the consistent way. And then what you do, the first step you do is that for each cohort, you analyze with regards to your question. You do it cohort by cohort, cohort by cohort. And once you have done it cohort by cohort, what you do now is that you obtain a summary estimate like we get from the published literature. But the difference here is that you have made everything consistent, all the variables consistent across the studies. So you do it separately. And once you have done that, you combine the estimate the same way we combine the estimate using Revman or Stata or however we did yesterday. You combine it. So you analyze each cohort separately, and then you combine the estimate the same way. This is one approach. when you want to estimate the overall effect. But if you want to do subgroup analysis, if you want to do things like interaction, if you want to evaluate the impact, and in this, if the consistency here is that you can also adjust for the same factors in the analysis and get the estimate. But if you want to do subgroup analysis, if you want to evaluate interactions, if you want to do some detailed analysis, then what happens here is that you bring all the cohort studies together into one file. You bring all the cohort studies together into one file, and you use what we call multi-level models to do that. This is the only way you can do that. And so when you do this, the studies, each study is taken into account by indicating the levels of analysis. So level 1 would be the study level. You indicate this in the multi-level that I want to take into account the differences between studies. And so you specify this level of potential variance in the study. And the level 2 will be the participant level. And here you can evaluate subgroups, you can evaluate interactions, you can evaluate other things. And David, from the question you asked, I think this is something perhaps you must have done. Is it?
We didn't do the subgroup analysis using multi-level. What we did was that we analyzed for each country.
Yeah, separately.
So yes, separately. For each region separately.
Each region separately.
Yes, so the subgroup analysis were within the regions.
Okay.
Yes.
Yeah, I think that is also acceptable. The multi-level is quite good because you can then account for the variance or difference that exists between regions, and you can estimate that. And you can somehow also integrate this for weighting the estimates.
Yeah.
So the variance at this level and the variance at this level. But otherwise, what you have done is also acceptable. It's just that I don't think there will be too much difference in this, but taking it this way will give you a lot more information that you may not get from here.
Okay. Thank you.
Yeah, sorry, I have the lunch break in the wrong place. So that is a short introduction to individual level meta-analysis. I don't know if you have any question. So this should be 10 minutes break and not lunch break. Any question? Is everyone getting tired or?
No question for now.
Okay. So
no, excuse me. Sorry, I don't know. Sorry, excuse me.
Yes, please.
I know you've outlined the benefits for doing an individual patient's data meta-analysis. Is it usually necessary for, what is the drive towards this? Yes, the benefits are there. I mean, can you do this as an independent study and publish?
What do you mean by independent study?
Like a study, like you're publishing a protocol of a study of a systematic review, or can you just do this as like you pick individual patients' data and then you analyze them and you publish the meta-analysis of that?
Yeah, that is the essence. So when we say it is the gold standard of meta-analysis, what it means is that that is what we should be doing. But we are getting estimates from the literature because we do not have the individual patient data from other studies. So this is the gold standard. That is what we should be doing. So what we have done, going to the literature and picking those estimates, extracting the data, it's the indirect way we are trying to estimate what would have done using the individual level patient meta-analysis. And what we do based just on the literature has limits of what we, and as I've explained here. So yes, this is what is required. If you're able to do it, it takes time, and is published. When you do it, it's even easier to publish it in good journals than publishing a normal systematic review. You can write a protocol, the same process, you write a protocol for this and publish your protocol beforehand. You have to also do quality appraisal of your study and so on and so forth. The only difference is that here you have the individual data and it gives you far more information than you have just with the summary estimate from published studies.
Okay, Prof.
Yes,
hello.
Yes, I'm here.
Yes, I want to ask, please, what proportion of individual data one gets, from the several requests you make to authors? What proportion will you consider satisfactory? And the second concern is, just suppose there is a significant difference in your estimates you obtain, comparing if you use the estimates from the studies and if you do the analysis from the individual data. What will be the significance? Because that is possible. It's possible that when you get the individual data, you do your result estimates, you find it quite different from the estimates you would have gotten if you used the individual estimates of the published works.
Yeah.
So what will be the significance of that?
Yeah, these are important questions. If we have already calculated the estimate based on those we get from the literature, and then later on we are able to get the individual data from the studies we have used previously and calculate and get the estimate from the individual patient data. The estimate from the individual patient data is more significant and should be used because it is the gold standard. So I think that is just a simple answer to that. But
will you report that is different?
Yeah, of course. And that's based on the previous literature, and only from published study should be discarded because you have done the right thing. What you have done before is only availability at the time. So science is progressive, knowledge is progressive, and we should be open to accept changes that occur even when they are contrary to what we knew before. That is the essence of how science progresses. And so if you have done the gold standard, then use the gold standard. Then the proportion of studies, before you can do this, there is no recommendation. As you can see from what we have done so far, if you have few studies that are positive to your request, you can do your analysis with that. And then you have to, when you discuss, indicate that others didn't give you data. So the estimates you have calculated can be generalized to the studies that you have included. You can't generalize outside that. And then you can also, when I mentioned yesterday, publication bias, there's what is called the trim and fill method I've mentioned, which you can also use to estimate if for any reason I have received data from all these studies that didn't give me, how will my estimate look? So you can make educated guess using the models to be able to estimate that. Then you can also estimate the possibility of that missing studies affecting the conclusion. So, but there is no guideline on how many studies you should include before you can do this. It's just for you to be aware of the caveats and then discuss your limitation in that respect.
Thank you very much.
Okay, David, you were raising your hand.
Sorry, this may be a silly question, but I was just thinking, is there any clearinghouse apart from these databases, that you can just know if a topic you are thinking about is already systematic review on that? It's only one-stop place that you can just.
So if you, that is why we encourage here, if you start to think about your systematic review and you have formulated your question, develop a protocol and register it. If you develop your protocol, if everybody is same thing, the place you go to find out is from the Prospero or other sources, and you search to see whether there is a topic going on there. And sometimes people may not register their protocol and publish a systematic review. So you should also search like places like Google, PubMed, some of those. Just do a quick search to see if there is something there, just in case people have not registered their protocol in Prospero.
So if you send your protocol to Prospero and it's already registered, they will advise you not to pursue.
Yeah, so you have to search first yourself before you even start to develop yours.
Yeah, true. Great, thank you.
Okay, we can take a 10 minutes break and come back to finish the last session. Let's come back, or let's say come back 15 past. Just take 7 minutes since we are just coming from lunch, and we'll continue from there. See you soon.
Thank you.
Just get the contact of all the UCC guys, UCC men and women on the program for me.
Right, I'll do that.
Okay, great. So Amanda and others, give your contact to Josephine.
So I suggest we create a WhatsApp group.
Yeah, so Josephine will do that. So just send your messages to Josephine Aka.
Okay.
Great, thank you. Sorry for bothering the others.
Please, you can me with those numbers. Thank you. I'll get it from there. Your emails and then those from UCC. This is Josephine speaking. Please, you can private chat me with your email addresses and numbers so that I can create the WhatsApp group. Thank you.
Okay. I think we can start now to see if we can finish this session, and then it will be all yours to go to your groups to continue to work on your project. So the last thing I want to mention is that we have taken a journey through this week. And I guess for many of you, this may be clear immediately. So for many, this is your very first time to really come across these issues. But the methods of systematic reviews have come to stay. And if you evaluate this critically in the positive way, you can see that the issues we have discussed here are not only relevant in doing systematic reviews, but they're also relevant in dealing with your specific research in other areas. So this is quite important for us. And you know that in every field of endeavor, there are always rooms for improvement as there are criticisms of what we do. So this section, I want you to reflect as we have gone through some of these issues. I'm going to present some of the criticisms that have been leveled against the systematic review and meta-analysis, but mostly against systematic review, meta-analysis. So it would be good to have your feedback in a way if you think you have something to say in any of these sections, and if there are questions. So there are a number of criticisms that have been pushed against meta-analysis, and the key ones I have listed them here. One is that once number cannot summarize, or one study cannot summarize a research field. The second one is five drawer problem, mixing apples and oranges, garbage in, garbage out. Important studies may be ignored in this process. Meta-analysis disagreeing with randomized controlled trials, and that meta-analysis are poorly done. So I will go through each of these one by one, and please interrupt me if there is anything you want to say. Okay. The first criticism here is that one study cannot summarize a research field. And here the criticism is that when you do meta-analysis, there is so much focus on the summary effect. And when you focus on the summary effect, you ignore the fact that the studies vary. The effect estimates vary across studies. That is an important criticism. Baller in 1997 in the New England Journal of Medicine brought these criticisms, and he said that any attempt to reduce results to a single value with confidence bound is likely to lead to conclusions that are wrong, conclusions that are wrong, perhaps seriously so. So how do proponents of systematic review and meta-analysis respond? And this is quite interesting here, saying that meta-analysis is a process that leads to meta-analysis. Systematic review is a process, and that is one of the things I tried when we defined systematic reviews and meta-analysis from the beginning. That the process of synthesis leading to derivation of summary effects is not just meta-analysis. We take a process, and I have shown you this process. And so the problem of this criticism is that many people equate meta-analysis, which is a statistical tool, to a systematic review. Meta-analysis is not equivalent to systematic review. Meta-analysis is a tool used to quantitatively deal with issues in a systematic review. So we emphasize on the process and not just on the summary effect. I told you that meta-analysis can be used to achieve two objectives. One is that it can allow us to evaluate differences across studies and try to understand why these differences are. And in doing that, the emphasis is not on just deriving the summary estimate. The emphasis is to understand the differences. And then meta-analysis can also be used to derive the summary estimate. And in also deriving the summary estimate, we don't just do it and we say, hallelujah, here we come. This is our answer. No, as you saw yesterday, once we have the overall estimate, we can ask other questions. Can there be anything that we can evaluate more that will help us to get insight? I discovered even though we used a fictitious data yesterday, we are able to separate the cohort studies from the case control studies. And that also gave us a signal of what might be happening there. We did for quality of the studies, and that also gave us a signal. So it is not only summary effect that we are dealing with here. We are actually evaluating the evidence in a systematic way, and we can, through the systematic processes of doing this, reach a conclusion that is beyond just the summary effect. So we look for consistency of effect. We look for inconsistency of effect and evaluate reasons for this. Reporting summary effects and ignoring the reasons for this, we miss the point. And that is what we should avoid once you start doing your own. The second criticism relates to publication bias. So the criticism is that meta-analysis is biased sample of all possible studies. Thus, summary effect will always be biased. Studies with high treatment effect more likely to be published, and including meta-analysis. Unpublished studies end up in researchers' filing cabinets. Yes. Of course, we have gone through this, and I think you are so much convinced of this to know that when we go out there and publish, we should also know that there are possibilities that those who have done the same thing we have done and have not been able to publish it. So what we have published may not represent the global number of studies on that topic. That is a fact, and we have to accept it. That is a problem for literature reviews, not only for systematic reviews. As far as we go out there to look for literature, is always a problem. And so this is a legitimate concern. But like we have said, encouragements and improvements made now, we can be able to use available and emerging sources to search for literature. And I mentioned this yesterday, that you should take advantage of that to make comprehensive search. There are registers for studies, ongoing studies, registers for protocols, and we should take opportunity to ensure that we have exhaustively done what we need to do to identify the studies that are there. And quantitatively, we can use tools. They are not great or perfect, but they can at least help us to get a signal of what is happening. And doing this, we can integrate the results into the interpretation of what we found. Okay, any question this far? Okay, I will continue. The third criticism is that meta-analysis is a mixture of apples and oranges. And if you mix apples and oranges, I'm not sure what color it becomes. Has anybody done any experiment in the class? Anyway, oranges perhaps have the same color, but you see apples have different colors too. So it's a complicated scenario. And if this comes to reality that we're mixing apples and oranges, then we'll have problem in our hands. So here it says that researchers combine all kinds of studies in the same analysis. And so computed summary effect, we ignore known and salient differences between the studies. And if you do this, what color of the apples and oranges do you get? And what do you make out of this? Well, those who are proponents of systematic reviews and meta-analysis say, well, we admit this. Yeah, studies inevitably will differ in their characteristics. And most often, it's difficult to decide how homogeneous studies are in order to undertake meta-analysis. That is true. Researchers may sometimes make questionable decisions. Yeah, that is very common. People just really do this. But what is the problem here now? However, meta-analysis questions are inevitably broader than individual studies. And this goes back that it is not just the meta-analysis, it is a process we have taken to come to this point. Well, what we do, it is possible that we are interested in effect of fruits rather than just apples or oranges. Yeah, so what effects of this combination, we may be interested in that. And in doing this, the strength of meta-analysis is to quantitatively assess consistency of effect, and we're able to evaluate to separate the apples and oranges. We're able to do that when we do meta-analysis. So this criticism is very much positive criticism, but it also overlooks the real things we do here. The apples and oranges in meta-analysis can be combined. And like I said in the previous sections, the goal may be that we want to really identify and separate the effect of the apples from the oranges, and not just to get effect that combine both of them. But sometimes it may also be possible that we're interested to get the overall effect of the apples and oranges together. Okay. Criticism 4. It says any fundamental errors in primary studies will always be carried over to meta-analysis, and this may be hard to identify. So garbage in, garbage out. If the studies are of poor quality, you can't help to improve the result of the meta-analysis. Yeah, that is true if you do it that way. If you just go and do it, like the study I explained in the morning session, to say that these people went and did this study that we did before, and then mix everything, both those that have hazard ratio, those that have risk ratio, those that have odds ratio, mix them together. And a big journal accepted it. yeah, may succeed in that. But systematic review and meta-analysis is an iterative process. We start with a large pool of studies and we end up with small number of studies because we have a process that we perform different sets of decisions to reach that stage where we can then say, okay, these studies now are eligible to be included. So it involves decision we make. Studies included in meta-analysis may not be perfect, but we undertake a process that we can identify and be able to deal with the biases and the problems there. And you know that we also grade these studies. So in the meta-analysis, we can separate the low quality studies from the high quality studies and evaluate how they influence our conclusions. So this is the response they have to this. Criticism 5, important studies ignored. Yeah, in any meta-analysis, important studies will always be left out. That is a criticism. So if you do that, what is your conclusion if you leave these studies that are important? Yeah, we have said this before. Systematic review and meta-analysis is an iterative process with explicit mechanisms and decisions and judgments made in the process. We screen the studies for inclusion. We use our exclusion and inclusion criteria to go through each step, and then we base this on the process we have indicated before. And so the process we go through here is transparent, but more importantly is that it is good to be aware that the question Urban was asking, if you do this and studies are excluded, please ensure that when you discuss, you have to acknowledge this so that when you generalize your findings, it should be generalized appropriately, acknowledging that some studies have been missed because we couldn't get them. But eventually those studies were there. How would that influence the decision? So we need to be aware of this, but within the process we do this, we have a way of dealing this, even though this is an important criticism, but we have a way of doing this. And for us, having come to this course, let your interpretation, let what you do have the consciousness of the fact that we may not always get all the studies that are there. Okay, meta-analysis may disagree with randomized control trials. In many cases, there is a disagreement with subsequent randomized control trial on the same topic. What is the response? Clearly, this is not a problem of meta-analysis. Why will it be a problem of meta-analysis if they say that garbage in, garbage out? So when they criticize us, maybe they don't even think about this. But this is important that if this happens, it's not a problem of meta-analysis. I think it should be a problem of the clinical trials included in meta-analysis, that they actually disagree with themselves and not that the meta-analysis is the problem here. So there is evidence that indicates that a third of randomized control trials disagree with each other. That is the world we live. And why is that so? Because so many things happen. Researchers can be sleeping when they're making measurement. Well, not very common. But many things happen on the process that can lead to this. And when it happens, it is not really the problem of meta-analysis, but maybe a problem of the studies themselves, how they are made. And this can come in different ways. Populations included, the method used, the outcomes, and how these have been measured. Criticism 7, meta-analysis are poorly performed. I can't say this or emphasize it more than this. We have talked through this throughout. Tuesday, we started this. You can see people making decisions in using fixed effect, making the wrong decisions. We have emphasized it here. And so if you submit your paper and maybe the journal for some reason sends it to me and I see that you have made the wrong decision, don't be surprised. I will say to the editor, please reject immediately. Anyway, so the point here is that this can be done poorly, and we need to ensure that it is done in the right way. So I said that meta-analysis are so complicated that they contain mistakes. Are they complicated that they contain so much mistakes? Editors may unlikely uncover such mistakes. Yes, from the critique you had today, you can see this can occur even in the top ranking papers. And all the papers we looked at this morning are published in the top ranking journals. Yeah, many meta-analysis contain errors, some important errors. The systematic review meta-analysis is a process that aims to cushion strategies to avoid mistakes. Yeah, such mistakes are clearly flaws in application of the methods, not a problem with the method itself. It's a problem of the researchers. They can really do a lot of things, like the study I mentioned now, where they combine odds ratios, risk ratios, hazard ratio, put everything together. The goal is that we just publish this and get it. The question is, what influence does that have in decision making? This is a very important question to ask, because that is why we do this. If that evidence is used by those who don't know the process here and say, oh, do you know this study showed this? Wow, we have been doing the wrong thing. But that may be that the process leading to that result is flawed. And that is what the problem is. So we cannot condemn a method just because a bunch of people are misapplying the method. No. So this is the last criticism. I don't know, please, if you have anything, if you have your own criticism you have raised, please, let's bring it up. And if you have any question with this aspect, but so far, so good. I think my work has been done to highlight this. Let me hear from you. Any question? Is anyone there?
Yeah, here thinking.
Everything is so nicely presented that I hardly get anything. But I think that it's a very good advice to us that even though we've learned a lot from you, the zeal and the appetite to just start pulling data and start running systematic review. But as you emphasize over the course, it's something that we have to learn gradually and learn the best practices.
Of course, of course.
And then we should target the top journals, but also we must learn the best practices, because you emphasize again from the exercise we did this morning that even in the top journals, your bad method can escape their eyes.
Mm-hmm.
So I think this message is very clear for us this morning.
Okay. Any other points?
I have a question.
Yes, please.
What is the best way to start writing a systematic review? Start with the narrative, which appears much more simpler. Maybe take 2-3 databases, PubMeds, Embase, and even one other one. For a starter, for someone who is just starting, what is the easiest way to start it?
There's no easiest way. There's only one way. And that one way is to do it the right way. And that is what I will continue to emphasize here. We are not looking for the easy way. We are looking for the right way. So please don't go for the easy way. Look for the right way. But if you are asking the question,
I don't mean easy as per, okay,
yeah, if you're
asking narrative
question,
review is a form of systematic.
So narrative review, expert review, those are different from systematic review. If you're doing systematic review, it has to be done according to the prescribed processes. But if you're asking for a starter, how do you go through this? How do you learn? How do you become an expert? And that is what I have offered here since the beginning of this week. If you want to intensify this, you think you have the time, you have the energy, you have the inspiration, I offer that I can get you involved. I have done this across places, and people come for collaborations as well so that they can be guided through the process. So if you want, you have time. I have really taken people and I discarded them because they don't have time to really keep to their promise. But this is what you can do. Attach yourself with a team that is already doing this, and then they can help you and guide you. You can learn from there, and you start growing independently on your own. Otherwise, there's no easier way to do it than to do it in the right way, but you can learn from others to improve. And that is how most of us have done it as well.
That's fine. Thank you very much. I like that.
Okay. Any other thing? Orban, did you?
Yes.
Okay. Go ahead.
Yeah, Prof. I appreciate these criticisms and the way they are responded to. It provides a holistic picture of the entire training. But I want to assume that these criticisms of systematic review and meta-analysis also apply for umbrella review.
Of course.
Good. Now, I would make a point here for the criticism 7 that the criticism of it being poorly performed, one of the responses could be that an umbrella review seeks to, in a way, weed out systematic reviews that may have been poorly done.
Mm-hmm.
I don't know if that assumption is correct.
Yeah, of course.
So if that was included as a response, to the critics of it being poorly done, I think that would be more complete response.
Yeah, that is also the point there that it's not the problem of the process, it is problem of the researchers because they apply the process in the wrong way. The word weed out, it's not just to weed out, is to make a statement on them to say that this is poorly done, this is not convincing evidence. This is a convincing evidence. So the processes allow us to do that. And if the processes are well utilized, then our answer will be with high confidence. But if the processes are not well done, then we can't run away from this criticism. Then it becomes a problem of the researchers and not the method itself.
Okay, just the last one, a futuristic statement. The way the umbrella reviews have come up in the past 10 to 12 years, it looks to me as if sometime much later in the future of scientific research, we will have a need for review of umbrella reviews. Is that thinking too aloud?
Yeah, maybe we'll call it aeroplane review. Anyway, the point there is that science is progressive. Science is progressive, and please let's allow that to be. Don't stick and hold your feet and say, "Do you know when I started? You were not even born. How can you come to change?" No, that is not the way it is. We are human beings. We are liable to mistakes. We can fall apart. Our knowledge may be wrong, and so on and so forth. Even without doing a systematic review, I can tell you this. When I started my research, doing my PhD, I was working on looking at diet during pregnancy, diet during infancy, and see how that influence the development of asthma and allergy in children. And already we know that there is international recommendation on breastfeeding. Breastfeeding is very important for children. That is known, it has been established. There is no argument with that. But the recommendation of the knowledge of what breastfeeding does has been applied across different diseases. But the question is, in the area of allergy and asthma, does exclusive breastfeeding and breastfeeding, as has been recommended, play any role? That was one of the questions I was asking in my research. So we started doing this, and eventually we found out from one of my studies that really exclusive breastfeeding appears not to play any role in protecting the development of asthma and allergy in children. Rather, early introduction of solid foods seems to be protective. And then children can continue breastfeeding for a longer time. So you introduce food early and continue breastfeeding for a longer time. That was the conclusion we reached in our study. And once we reached that, and this was published, it was one of the journals in pediatrics that published this. Goodness me, we got called from all over the world asking, how did you get to this? Because the conventional knowledge is this. And so this journal published it because there were already some signals coming from different parts of the world that this actually may be the case with regards to asthma and allergy. But many people didn't believe that when our study was published. Then after a few years, you see many other studies started reporting the same thing. And what has happened that it led for a clinical trial to be organized, recently published in New England Journal of Medicine in JAMA, in which they indicated, for instance, with regards to peanut allergy, that if children are given, for instance, peanuts early, it seems to be protected than those children who are denied peanut if they have risk of developing peanut. And so immediately, the International Organization in Pediatrics and Allergy, they released a statement, interim statement, to say that this is what we have now. And so we will advise clinicians to apply the knowledge we have carefully, because our understanding previously may not be a perfect understanding, why more research is going on. So what I'm saying there is that science is progressive, knowledge is progressive. If we know all, we will stop the research. One of my friends always calls me and said, when will you stop this, your research? Every time you're researching your research, when will you stop? But we can't stop because we don't know everything now. So let's open our mind as we go on, because some of the things we know now may be different in the next 20 years, in the next 30 years, because our knowledge has increased. And so that is how it is. Yes, it is possible that in the next 10 years, in the next 20 years, instead of umbrella review, we'll have aeroplane review or skyscraper review, whatever they will call it. But the point is that a process through which we can fine-tune and do better what we're doing in this area. Thanks for pointing that out.
Thank you, Prof.
Any more? This is my last session of teaching, so please take advantage if you have anything while I put you in your group. Just a minute. So I'm listening if you have anything.
Prof, thank you so much. Actually, I don't really have question now. I think we'll read and digest the topic very well for some of us that are very, very new.
Yeah.
So maybe next time we'll, keep on bombarding you with mails and all that.
No problem.
Thank you so much. Thank you.
Okay. Just a minute. Let me put you in your groups, and you go there. One thing I would like to say, I will come back to that just in a minute, is that I have made an evaluation of this course, which I will send later today the link to you so that you can please help to evaluate the course. I've used the evaluation form we use here at the university here, because my goal is that as much as I have time to present this to our African scholars, and if I can do this yearly, so the evaluation will be helpful for me to see areas that I can improve the teaching of this course. So please, when you get the link, it is anonymous, so feel free to criticize in any way areas that are difficult, suggestions you would like to make. Just do it. It will be helpful for me to improve the course next time. Okay, I just finished this.
Sorry, right?
Yes,
can I ask you a question on basic statistics?
Can I ask one thing?
Yeah, Godfrey first, then Job.
Yeah.
You
DC Dropbox.
Yeah, Dropbox. What happened?
Dropbox, where we are having the resources. How can we access it?
The Dropbox. Godfrey, you're the one asking.
Godfrey asking a question.
Yeah. I sent if you have your email, I sent all this to the emails.
Then
I sent it to the emails I have for the participant. Don't you receive my emails?
No, I've not received the resources.
You have not received, or maybe the address,
no,
email address you use.
I think you are sending to my office email, the Hotmail. Yeah.
That is the email I have for registration. So I used the registration email to send this.
Okay.
Yeah. So unless I have the wrong email for you.
Okay.
Yeah.
Because I'm not really getting all these resources. Okay.
So, but if you have a different email, you want this, just send that to me and explain your situation so that I can forward the link to you so that you can have access to those materials. Okay.
Sorry.
Yes.
Can I ask you one simple one? I beg, can you help me explain the errors? I know it's outside this study, but I want to get it clearer in my head. You were then to talk about the odds ratio, hazard ratio, and then risk ratio again, so I can fit it properly.
What do you mean?
The ratios you were trying to explain before when you're talking about the umbrella review, about you made reference to odds ratio, risk ratio, and hazard.
To be frank with you,
it's maybe outside the scope of what you're doing, but
yeah, this is really beyond the.
I know it's basic statistics. It's basic statistics, but
this is beyond.
You have a fine way of explaining things like this. Systematic review. I know.
It's beyond this. It's beyond this course. It's beyond this. It's beyond this course.
I know.
What I could do is in the future, what I have planned is that all of you, as far as I get people who attend, I will put them on the email list. I know that the basic epidemiology, not all profession have that. So I think it will require having a course on a basic epidemiology to explain this. Otherwise, we don't have time to do that here. And really to get that, you need other prior knowledge of study design.
That's fine.
Yeah. So sorry about that. Okay, this is what I want to show here. Please, I will send this evening, and you can feed that. Then,
thank you.
The work for today, you can do this or continue where you stopped. There's something just a minute. I need to show you too before you go. This morning, yeah, this one for tomorrow, because it looks like some groups you're already planning to write a thesis. We don't want a thesis. What we want is a succinct summary of what you have done, and it should be not more than 10 minutes presentation. So we need a PowerPoint presentation. So I will keep this open so that you can note it when you organize your presentation tomorrow. I'm really looking forward to it. This is always the most exciting part of the course for me, to see how you have navigated through this, to see how this course has come through to you. So please make it nice, add funny parts, and let's see what you have done. So 10 minutes presentation, and you can think of these things, how you have performed these different sections of the course. Okay, if nothing else, I will send you to your groups, breakout groups now, and if anything, just let me know, and I will come to your group. See you later.
Thank you.
Thank you.
Thank you.
Okay, it's group 5, eh?
Thank you.
I had network issues, so I couldn't connect to my group. Breakout group 3.
Yeah, I sent you the Apostle.